It's time for another enlightening edition of Clot Conversations. I'm David Airdrie from Thrombosis Canada, and alongside our expert co-hosts, Dr. Maha Othman and Dr. Jamil Abdurrahman, we're bringing you the latest breakthroughs in thrombosis, diagnosis, and management. Hear from leading researchers, discover cutting-edge techniques, and explore the resources Thrombosis Canada offers. Let's get started.
In this episode, we will be discussing a paper from Thrombosis and Hemostasis entitled Multidisciplinary Expert Guidance for the Management of Severe Bleeding on Oral Anticoagulation. We're pleased to be joined today by two of the co-authors, Dr. Siraj Mithoowani and Dr. Deborah Siegal.
Dr. Siraj Mithoowani is an assistant professor in the Department of Medicine, McMaster University, and works as a clinical hematologist at St. Joseph Healthcare Hamilton, where his practice is focused on non-malignant and thrombotic blood disorders. He completed his medical degree, residency, and fellowship at McMaster University and graduated with a master's degree in health professions education from Maastricht University in the Netherlands. His research interests are in knowledge translation, laboratory monitoring of anticoagulant, and postgraduate medical education.
And Dr. Deborah Siegal, a clinician scientist hematologist in thrombosis medicine at the Ottawa Hospital, associate professor of medicine and School of Epidemiology and Public Health at the University of Ottawa, and scientist at the Ottawa Hospital Research Institute. Her primary research interest is improving the safety of anticoagulant therapy, including optimizing the management of anticoagulant-related bleeding complications, restarting anticoagulants after bleeding, perioperative management of anticoagulants, and antithrombotic therapies for ischemic stroke in patients with cancer. Dr. Deborah Siegal is a member of the board of directors of Thrombosis Canada. Thank you for participating in our podcast. So we'll get started with some questions.
So I think to begin with, I would like to ask, what was the motivation for this expert guidance document on the management of severe bleeding on oral anticoagulation?
Paul, it's really a pleasure to be here with Dr. Mithoowani, my friend and colleague, to talk about why we developed this important algorithm and published it as a manuscript. And there is a lot of data regarding the management of patients with bleeding on anticoagulants. And this is actually quite a common problem. And what we felt was really missing out there in the literature was practical guidance for a clinician on the front lines of therapy who are seeing these patients come in with a bleed. And we felt that the importance of having a document like this is to help, people standardize management, to expedite treatments and investigations, definitive management, initiate treatments like reversal and other pro-hemostatic therapies, and then to remember some of the important management principles after a bleed has resumed, which is really all part of the same framework of bleeding in general. So treat active bleeds or severe life-threatening bleeds as they're happening, and then think about after a bleed resolves, trying to prevent another bleed from happening and ensuring that patients have decisions about whether or when to restart anticoagulants after bleeding in one nice, easy place for them to do so. So accompanying this, we actually included some clinical cases, which are examples of really common scenarios, such as gastrointestinal bleeding and intracranial bleeding. And we included a panel of experts from across Canada in different areas representing different perspectives: gastroenterology, internal medicine, critical care, hematology, pharmacy, etc. So I think this is, a way for people to, either use a really practical approach with an algorithm that they can put up on the wall in their emergency department, for example, or they can go into a bit more detail for some additional guidance, all in kind of one place.
That's excellent. Thank you.
Right. So you alluded to this a bit, but why is it important to have a protocolized, multidisciplinary approach to bleeding on anticoagulation?
Thanks, Jamil. So I think we can all agree that the indications for anticoagulation are expanding, and the number of prescriptions for oral anticoagulants is increasing year by year in North America. Now, if you look at direct oral anticoagulants, we know that they're safe drugs, but despite that, oral anticoagulant-associated bleeding is still a very common adverse event that brings people into the emergency department, leads them to a hospital admission, and causes mortality. So if you look at DOACs, major bleeding affects 2 to 4% of patients, of DOAC-treated patients per year. And another 10% of patients on DOACs experience clinically relevant non-major bleeding on an annual basis. And as you know on this call, and many of our listeners would know, major bleeding is especially associated with a high mortality rate. So this is all to say that there are a lot of bleeding emergencies that people handle in the emergency department and critical care units and in the hospital. And therefore, having a protocol for handling these emergencies is warranted. Um, the ultimate goal of having a protocol like this would be to identify the patients that are at risk of the worst outcomes, to be able to guide the use of supportive measures like blood products, to have some multidisciplinary guidance on treating the source of bleeding, for example, endoscopically or by surgery, and then also to provide clinicians with some guidance about how to use anticoagulant reversal drugs or other hemostatic therapies like four-factor prothrombin complex concentrate in a judicious manner. And in particular, anticoagulant reversal drugs, they're costly and they are associated with an increased risk of thromboembolism, which highlights the fact that they should be prescribed to the patients that are most likely to benefit.
So the paper took a very elegant and informative approach in dividing the work into steps of management of severe bleeding. So why don't we go through the steps? And the first step was really to identify severe bleeding. Could you tell us why this is important and how should we do it?
Sure. So I think, the starting point for us was thinking about the how physicians are going to be accessing some sort of resource like this. So the patient comes to the emergency department with a bleeding complication. And patients can have a bleeding complications of a variety of severities, like ranging from, very mild, in self-limited epistaxis, right, all the way to, bleeding in the brain that's life-threatening, or perhaps hemodynamically unstable gastrointestinal bleeding. So it's important for us to then say, we want to focus on severe bleeding complications. And we took a different approach than some other publications, which have talked about what Dr. Mithoowani mentioned, which is major bleeding. And that has a very specific definition. And there are a number of them out there, most commonly the one that's used from the International Society on Thrombosis and Hemostasis. But there are some important limitations to that definition because it includes things like fatal bleeding and critical site bleeding, drop in hemoglobin, or even the number of transfusions performed. So it's almost like some of those criteria are retrospective. But when a person comes to the emergency department or shows up in the intensive care unit, for example, with a severe bleed, they're going to look as though they have certain signs and symptoms that I think we ought to pay attention to, like hemodynamic instability, which isn't really captured in clinical trial definitions of major bleeding. So we really wanted this to be about identifying people at the bedside who have signs or symptoms of severe a bleeding that could be life-threatening, and depending on the site, of course. And the treatment is very different. So you're not going to treat somebody with self-limited epistaxis the same way that you would treat someone who's having intracranial bleeding. And so we thought to focus on patients with severe bleeds. That's the most important first step, really, is to say this person's having a severe bleed. I need to pay attention, and I need to kind of put into place a series of steps, as you mentioned, that are going to help me optimize the management of this patient in an expedited way, assuring that they have supportive measures and perhaps other treatments and definitive interventions, as we'll go into. And it all starts from really identifying the person at the bedside who's sick in a rapid fashion.
That's fair. Thank you.
So step 2 is initiate resuscitation and supportive measures. Can you give us an overview of what that entails?
Okay. So, of course, this is something that's very common to patients who are presenting with severe life-threatening bleeds. We want to make sure that they are receiving resuscitative and supportive measures as soon as possible. And this is well within the scope and expertise of folks on the front lines in the emergency department, for example. It's really important to identify people who are having severe bleeding and to temporarily interrupt their anticoagulants while we're making sure that we're managing their bleeding complications. Resuscitation is clearly important and in a monitored setting, which is conducive to making sure that the person is receiving all of the interventions, such as intravenous fluid resuscitation, perhaps their need of transfusion. And this is again site specific. So a person with a severe gastrointestinal bleed is maybe not going to require the same types of resuscitative measures is someone who has an intracerebral hemorrhage, right? Because there's, of course, important protocolized management pathways that optimize the support of patients with those bleeding complications. So it's not a one-size-fits-all approach. There are some additional treatments that we might think about to support hemostasis, such as tranexamic acid. And we do know that there's a vast literature supporting the use of tranexamic acid for patients with bleeding complications like postpartum hemorrhage, those who have cardiac surgery, orthopedic surgery, trauma. But there are limited data regarding the population of patients who have bleeding associated with an anticoagulant. Regardless, this is something that can be considered in the right clinical context. And just to remind people again, supportive measures, transfusion, resuscitation with intravenous fluids, all of that stuff is going to help keep a person from having an adverse outcome and potentially from dying until definitive interventions can be administered, until potentially other types of treatments can be given.
That's great. So step 3, determine whether clinically significant anticoagulant effect is present. This is a critical step. Could you tell us, is that a more of a clinical assessment or dependent more on the lab test results?
Yeah, so thanks for this. It's a very important question. And I think that the key message in step 3 of this paper is that this is still largely a clinical determination, but may be supported by laboratory investigations. So in the paper, we suggest that for DOACs, that a clinically significant DOAC concentration is likely present if the last dose was taken at some point in the last 24 hours. Meaning, in other words, that less than 2 to 3 half-lives have elapsed since the patient last took their dose. Now, keep in mind, though, that this is an average duration, so it wouldn't account for the dose of DOAC the patient has been prescribed, whether they have kidney or liver dysfunction that might prolong the half-life or alter the drug's pharmacokinetics. And it also doesn't account for any relevant drug-drug interactions, which again may alter the pharmacokinetics. So, therefore, we believe that coagulation tests can be helpful when there is uncertainty on whether there is a clinically significant concentration of DOAC present or not. Now, this is under the assumption that the coagulation tests can be ordered and also reported and interpreted in a reasonable time frame to actually allow for clinical decision making. So for warfarin, which I haven't even touched on yet, the coagulation test of choice obviously is the prothrombin time, or INR. So I don't think we need to get into that too much. But coagulation lab testing for patients on DOACs is rather more complicated. So in table 2 in this paper, we outline our approach, and basically it boils down to whether or not you have access to a drug-specific quantitative assay or not. So dabigatran and factor Xa inhibitors can be quantified using a drug-specific assay, either a dilute thrombin time for dabigatran or a calibrated anti-10A assay for factor Xa inhibitors. And if using a specific assay, then a drug level less than 50 nanograms per milliliter is unlikely to be associated with impaired hemostasis. And that's basically based on expert opinion from the International Society on Thrombosis and Hemostasis. For other routine laboratory tests like the INR and the APTT, these need to be interpreted with a lot of caution because a prolonged clotting time, like a prolonged prothrombin time or APTT, might indicate a clinically significant amount of anticoagulant is present, but these tests can't be used to rule out the presence of a DOAC. So that's when things get a little bit more murky on the utility of those tests. And keep in mind the sensitivity of those assays depends on your local laboratory's instrument and reagent combination. So it's hard to draw to provide a definitive recommendation that could be applied across clinical labs.
Wonderful. Thank you.
So step 4 is administer anticoagulant reversal or hemostatic therapy if indicated. When is anticoagulant reversal indicated, and which reversal agents do we have access to in Canada?
So in this paper, we basically emphasize that anticoagulant reversal or the prescription of a hemostatic therapy like prothrombin complex concentrate would be indicated for patients that are experiencing severe bleeding and in whom a clinically significant anticoagulant effect is suspected. Okay. So for warfarin, the principle would be to measure an INR and then administer 4-factor prothrombin complex concentrate along with intravenous vitamin K for a bleeding emergency. For dabigatran, idarucizumab is Health Canada approved, and it's a specific reversal agent for dabigatran. It's actually a monoclonal antibody fragment that binds dabigatran with high affinity and reverses its effect. And the dose of idarucizumab is 5 milligrams intravenously. For factor Xa inhibitors, there is a specific reversal agent, as I'm sure you know, which is andexanet alpha. And that's a synthetic inactive factor Xa molecule that basically acts as a decoy to counteract the effect of factor Xa inhibitors. And dosing of that is a little more complex. It's outlined in one of the tables in the paper, but there's a high dose or a low dose regimen that amounts to either administering 5 vials of the drug or 9 vials of the drug per reversal. Now, andexanet alpha is a Health Canada approved product, but it's not reimbursed by most Canadian hospital formularies. And that means that most Canadian institutions are using an off-label product for factor Xa inhibitor, a hemostatic therapy for factor Xa inhibitor associated bleeding, and that will be 4-factor prothrombin complex concentrate or PCC. So just to emphasize that this is an off-label use of the product, and it doesn't reverse the anticoagulant effect of factor Xa inhibitors, but it does likely aid hemostasis by overcoming the anticoagulant effect of those drugs. And even the dosing of PCC varies by institution. Some institutions recommend a fixed dose between 1,500 to 2,000 units of the product. Other institutions use a weight-based dose. So those are kind of the options available for hemostatic therapies and reversal drugs, at least in the Canadian landscape right now.
Well, thank you for this wonderful clarification. While we are on step 4, I'm wondering if you can comment on deciding between andexanet and PCC for severe anti-TNA-DOAX bleeds, if you have comments on this.
Sure. This is actually a really important topic since the results of the Annexa-I trial were reported last year. And Annexa-I was the first randomized controlled trial which evaluated a DOAC reversal strategy. And it compared andexanet to usual care. And the usual care could have included 4-factor PCC and actually was given to about 86% of people. So now we have some randomized controlled trial data to help us understand the incremental benefits and harms of this treatment. And in that particular trial, the individuals who received andexanet for intracerebral hemorrhage, okay, so patients with bleeding in the brain, had a reduction in hematoma expansion. And people may or may not be familiar with hematoma expansion as probably the most important predictor of outcomes after intracerebral hemorrhage. This is, of course, a condition which is associated with high mortality of about 40%, and a large proportion of survivors of intracerebral hemorrhage have permanent functional impairments. So this is a very morbid, fatal condition. And challenging to do clinical trials, important data that we have randomized data. However, what we saw was improvements in hematoma expansion with andexanet compared to usual care. We also saw improvements in hemostatic efficacy, which was defined using kind of standard criteria that were developed in conjunction with the FDA. But we saw a signal for increased thrombotic events among people who received andexanet compared to 4-factor PCC, and that was primarily ischemic stroke and some myocardial infarction. So the question around which agent is optimal is really much more nuanced these days. So the first thing I think I would think about with regards to which to use is what do you have available at your institution? And so that's really helpful. If you don't have andexanet at your institution, it's not going to be helpful in an emergency where someone's life is at risk right in front of you. And I think, some of the sub-studies and analyses that have come out of the Andexanet trial and the Andexanet program have suggested that maybe there's some characteristics that can be helpful when making this decision. For example, a person who has had a prior thrombotic event, people who had prior thrombotic events in an XI appear to have a higher risk of subsequent thrombotic events after they received Andexanet, for example. Okay. But I think, again, these are nuanced discussions that should be discussed with a multidisciplinary team. At our institution, we have a code stroke team with stroke neurologists who attend all of these patients in an expedited fashion. And sometimes there are discussions around, who would be a candidate for what treatment. But I think so at the, until we have additional data about whether, patients with hematoma expansion have similar or better or worse outcomes compared to those who've had thrombotic events, it is still remain kind of challenging. What we can say is that we don't really know, we don't have high quality evidence about the effectiveness or efficacy even of four-factor PCC with respect to clinical outcomes, because the data are primarily derived from single-arm observational studies of patients kind of treated in routine practice as opposed to a clinical trial. So it may be that that PCC doesn't have an effect on efficacy in the way that we saw with the Anexa trial. The other important thing I wanted to mention, Dr. Othman, is just to say that this trial the follow-up for this trial was 30 days, and it's important to recognize that there was no difference in mortality or functional outcomes at the end of that trial, at the end of the 30 days, and it was really designed to be a hemostatic trial, like to understand how Andexanet affected hemostasis compared to PCC. But what we would really be interested in understanding is the long-term outcomes, because of course, individuals who have intracerebral hemorrhage, it can take a really long time for us to start to see clinical benefit because the blood is sort of sitting in the brain and has all kinds of ill effects when it's doing that. So we wouldn't expect to see improvements in functional outcomes until 6 or 12 months after these types of events, which is a bit unfortunate for us to understand that. But with respect to hemostatic efficacy and hematoma expansion, Andexanet appeared to was effective, but there was a signal of increased thrombotic events in ischemic stroke.
Amazing guiding comments. Thank you so much.
Okay, so step 5 is restarting anticoagulation after bleeding. Could you provide us a bit of a framework of when and how to restart anticoagulation?
Thank you. This is something actually that is really commonly addressed in clinical practice. Of course, every patient who comes with an anticoagulant-related bleed is on an anticoagulant for a reason, some sort of prothrombotic condition, be it short or long term. And so it's really important that after the bleeding has resolved to consider whether or not anticoagulant resumption is appropriate. And so, unfortunately, there is no one-size-fits-all approach. And you can even imagine with respect to gastrointestinal bleeds or intracranial bleeds, there's a vast difference between the rebleeding risks and the etiologies for those bleeds. Even within GI bleeding, for example, you have many different kinds of bleeds with different etiologies, all with different rates of recurrence. That it's very important to understand what type of bleed you're dealing with. So I think the way that I think about restarting anticoagulant related bleeding is, number one, did the patient stop bleeding? Because if the patient has not stopped bleeding, you're not going to restart their anticoagulant. So I think that's helpful. Sometimes in situations where patients are at high thrombotic risk, for example, like mechanical heart valves, people are quite concerned about restarting anticoagulants. But if a person is today having a life-threatening intracerebral hemorrhage, today is not the day for us to restart their anticoagulants, and that can be reassessed. So again, there needs to be a plan in place to reassess. So has the person stopped bleeding? I think that then the second question to me is, do they still need to be on an anticoagulant? And sometimes it's very clear. Maybe they've been on an anticoagulant and just nobody has gotten around to stopping it. Let's do that. That's a very important value add to that patient if we can stop anticoagulants if they don't need them. But then there's this tricky scenario of patients who still have a prothrombotic condition and they do need anticoagulation. Then we want to look at both sides of the coin. On one side we have recurrent bleeding, and on the other side we have thrombosis. And so I encourage people to think about these not just in terms of the absolute rates of bleeding, like let's say in a month, in a year, in 10 years, but also to think of the consequences of bleeding. What is the site of bleeding? Is it amenable to intervention? Is it likely to occur again? It's very different to have an intraspinal bleed than it is to have recurrent epistaxis, for example. These are not the same, and they don't have the same implications for patients. Similarly, thrombotic events are different. A recurrent deep vein thrombosis has different implications for patients than an ischemic stroke, following which, a substantial portion of people have, permanent functional disability. So I encourage people to speak to their colleagues in these, gastroenterologists for GI bleeds, neurologists for intracerebral bleeds, to really understand those risks of rebleeding, and then talk to the patient and their caregivers around what their preferences are in terms of bleeding. And I also wanted to just caution people that these decisions can sometimes change over time. So it is okay to defer decision making for later, but also to make sure that there's a plan in place about who is going to make that reassessment and when that reassessment is going to happen.
Right. So preventing future bleeding. This is step six, and it's very critical, also key. What are some of the ways that we could try to prevent future bleeding?
So thanks, Dr. Othman. I think Dr. Siegel and I basically both agree that when you have when you see a patient with an index bleeding event, and you've managed the bleeding, that is also a very good time to reevaluate the risks and benefits of anticoagulation, and to basically ensure that anticoagulation is being prescribed safely to that individual, and consider strategies for secondary bleed prevention. So, I think Dr. Siegel already alluded to the fact that the first thing you might want to consider is whether the patient actually does have an ongoing indication for anticoagulation. And if they don't, again, that will be a very opportune time to stop anticoagulant therapy. So some examples for that would be if patients experience bleeding on anticoagulation, but the indication for anticoagulation was a first provoked VTE that was more than 3 months ago, or non-valvular atrial fibrillation with a low CHADS-2 score. So those may be examples where we might consider discontinuing anticoagulant therapy to prevent future bleeding. Secondly, you might consider whether there is an intervention that could lessen the risk of bleeding after a specific bleeding event. So, for example, after a GI bleed, one might consider endoscopic treatment of a bleeding lesion, or treatment with a proton pump inhibitor. After intracranial hemorrhage, one might consider optimizing blood pressure control with antihypertensives if indicated. And the other things you might consider to optimize safety is to check whether the patient is actually receiving the appropriate dose of anticoagulation, because off-label dosing is very, very, very common. And we know that off-label dosing compared to on-label dosing of direct oral anticoagulants is associated with harm in the directions of thromboembolism for underdosing and excess bleeding for overdosing. So you might want to consider whether your patient actually meets criteria for dose reduction per the drug monograph. Okay. Then you might want to consider whether there's any drug-drug interactions that you need to take into account. The most common and potentially most serious one would be co-prescription of anticoagulants with aspirin or non-steroidal anti-inflammatory drugs. And co-prescription basically increases the risk of major bleeding by 2 to 3-fold in large, and that's been shown in large administrative health studies and cohort studies. You might also consider whether there are other over-the-counter or herbal medications that might be interacting with the anticoagulant that's being prescribed, and that might increase the bleeding risk. And we provide some examples of over-the-counter herbal medications that might fall into this category in table 5 of the manuscript. I think generally the principle then is also to reevaluate the patient on a regular basis, because DOACs are easy to prescribe, but they're not set it and forget it drugs. So although we don't need to monitor the INR regularly as we would need to do with warfarin, we do still need to reevaluate the risks and benefits to patients longitudinally, because the risk of bleeding is dynamic, and we might need to alter the prescription over the course of the patient's course of treatment with the drug.
Well, this is wonderful. I can see that you carefully thought about this step in your paper and your algorithm. Well, now that we covered all steps of this algorithm, I'm curious to ask, do you envision clinicians using this, and how do we help them or support them to use it more?
Yeah. So again, that's the hard part was to get all those experts together, and come up with something that we think could be multi-purpose for practicing clinicians. So on one hand, we have an algorithm that people can print out, put on their wall, use as a handy kind of reference. And it does have some detailed information, particularly around some of the steps that we talked about, including the lab testing stuff, where you might just want something to look at quickly, on the wall in the university department. But also, there's additional details around things that Dr. Mithoowani mentioned, around how to monitor patients, some important key aspect of different aspect of management. That can be a handy resource. I think the important thing for us in creating this was not to be overly prescriptive. This is really to provide a framework. This is to provide guidance for a way to think about these problems, which often, there's a lot of gray, right? Often there's a lot of uncertainty in how we manage patients with serious bleeding complications. When we restart anticoagulation, nobody knows exactly the right time to do that. Nobody knows the right dose of PCC to give if we're going to use that for hemostatic therapy. So I think, again, this is meant to support clinicians in decision making and can be used at the point of care or also as a resource for some non-urgent management, after bleeding complications can occur. So hopefully it will appeal to a wide range of audience. I don't know if Dr. Mithoowani, if you have any other thoughts about that. I mean, we're hoping that this is something that people will feel is of value by trying to address it in that way, and even by providing some clinical examples with some roles based on the experience of our collaborators.
Yeah, I think you're absolutely right. I myself see this as a way to structure even thought process and have a reference point to refer to so that you don't miss anything and you think about those things very carefully. So thank you for putting this algorithm together to support our clinicians.
So
You're welcome. Thanks so.
Sorry, go ahead.
I was just going to say thank you so much for the opportunity to talk about it. I wanted to also mention that, as you just reminded me towards the end, that one of the things that might be helpful for people is to be able to take this and, because it's not prescriptive, adapt it to their local context. We encourage people to use, whether it's this or something else, hopefully it's this, but or adapt it to your local context, exactly as Dr. Hoffman is saying, to create local algorithms and pathways so that care can be standardized and efficient, and that will hopefully lead to improved outcomes for these patients.
Wonderful.
And is there anything else we haven't discussed that anyone would like to add?
Not on my end. Dr. Siegal, do you have anything?
No, I think we enjoyed our discussion.
We did enjoy, of course, your answers and careful coverage and thinking about everything. I hope this is very informative to our audience. Thank you so much.
Thank you both.
You're very welcome. Thanks for having us.
Thank you.
Thank you all for this great discussion. And to our listeners, to learn more about the paper, the link is in the program notes. And the algorithm that Dr. Siegal talked about, it has been formatted and is also available on our website for download and posting on your wall if you want. And thank you to our audience for joining us on Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. Want to stay up to date on the latest in thrombosis? Hit the subscribe button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference. Your support matters. Consider donating to Thrombosis Canada to help us continue the fight against thrombosis.